Okay, get cracking then, Annabel. And when you've finished your presentation, we'll let the physiotherapists ask you questions, and then John and Steve and myself will ask you questions, and then we'll come back with some suggestions. It never quite works out like that, but that's the game anyway.
Cool.
All right.
So feel free to interrupt at any stage with questions as well. So I've got a 26-year-old LTA player who came into the clinic after failure of return to forehand. She's had a long-standing history of right intermittent shoulder pain, which was generally brought on by an increase in training load or hard court play. And her initial injury was when she was about 12 years old. Understandably, don't have a great history on what the actual injury was at age 12, but since then it's just not been great. She has a number of other issues going on. She is a normal BMI, but she does have red S. She was amenorrheic for a long time. She's got low progesterone. And she's had a couple of other niggly injuries. So she had a pubic stress injury last year, and then another kind of thigh injury, which queried femoral nerve, but no one really knew. It just kind of took a while to settle. And she'd been seeing the LTA physio and failed her return to forehand play. So they sent her over to me to have a second look at her shoulder. And basically it had come on, she'd tried to return initially 6 weeks ago after time off for this femoral nerve ? Injury, and it had been a bit niggly, which it generally is when she returns to playing. So she just kind of cracked on, and then it got a whole lot worse. So it was sore to, couldn't serve, couldn't play, couldn't hit a forehand, but also was sort of like take off a shirt, driving, lying on that side at night was waking her up. It did ease off when she had some time off, but yeah, as I said, she then failed a forehand return with the LTA. So just go to the next slide. This is her initial assessment, and then I'll give you a quick update because I actually saw her on Tuesday. She's actually going quite well. So Ruth asked me to present a shoulder case, and I actually didn't really have one that was really troublesome at the moment, but I thought this one was interesting, which is why I presented it. So her right scapula is slightly downwardly rotated, which, you know, in a tennis player maybe is not unreasonable. She had a deficit into flexion and abduction with some real decrease in that upward rotation towards the end of range, and her deficit into flexion was actually resolved when I assisted her scapular position. So she could attain full range with help. She was hypermobile into external rotation, restricted into horizontal abduction and hand behind back. Pec minor test. Now, I don't know if this is just a weird Australian test or whether other people do this, but lying on the bed and then front of a chromium to bed. So she was a 2 centimetre difference side to side, but that's quite high. You know, normally about less than 5 centimetres is good. 5 centimetres is good. Strength, her external rotation wasn't too bad, but her internal rotation was quite painful. She had a positive sulcus on the right, and in 4-point neo, she had really, really poor scap stability. She was also getting some right flank pain at that, not flank pain, sort of rib pain at that time as well, when she did some of her other rehab work that she'd been doing for her pubic stress injuries. She was on a progesterone-only pill. She'd been taking intermittent ibuprofen, but with minimal benefit. And she had a scan, and it showed bursitis, but the tendons were fine. So basically, for me, I was thinking that probably a lot of what was happening was, you know, she was getting some sort of internal impingement, which was causing the bursitis and irritation, secondary to poor control, poor strength around the shoulder, and maybe some underlying laxity. I did do a Baton's, you know, which is kind of a bit of a non-event really, but all the Baton scale was positive in her upper limb, but not her forward bend wasn't positive, and she didn't have hyperextension around her knees. So she'd had some soft tissue release, and she'd been doing a pretty basic kind of rotator cuff loading program with the LTA. And then she failed her return to play, and it seemed to be that they'd increased volume and intensity on the same day. So she'd done more forehand efforts, but then also some return serve work on the same day. And then, yeah, so I started with some scapular upward rotation drills, kind of like the Lynn Watson protocol from Melbourne. And that seemed to have started to improve her symptoms and working on protraction strength. So I actually saw her on Tuesday. She's going quite well. She has just started some return to forehand. She's doing half court is absolutely fine, 3/4 court absolutely fine. She did 40 forehand contacts last Friday with no problems, and then they decided to do 100 on Monday, so she was a little bit niggly on Tuesday, but I suggested maybe increase load. The load increase was too much. But what I was kind of hoping to get out of today was a couple of things. So one of her management team is really keen for her isometric internal external rotation ratios to be correct, as it were, before she returns to play. And I've found in the past dealing with hypermobile people, particularly at that 90-degree angle, it's not the greatest marker, and I can't find much research on it. So I was just wondering what everyone else's thoughts were about using that as a marker for this kind of population. Anything else that you think I'm missing? Any further investigations, and do you think if she fails return to play again, whether it be worth injecting the bursa? Really briefly, what she's doing at the moment in terms of home program stuff is some cross-body sort of diagonal work with the cable, some 4-point kneel. She's actually doing full push-ups again now. She is doing some loading up in internal external rotation, and that's actually she's managing that really well. She's doing only a couple of kilos at the moment. She's also doing some catching in supine and prone. But yeah, that's basically her. So I might have forgotten something. I haven't presented one of these for a long while, so feel free to ask any questions or come in with comments.
Annabel, that was great. Do you want to just give us a summary, because you covered quite a lot of ground there?
Yeah.
Just a brief overhead view of the patient, just to jog our memory.
Yeah. So 26-year-old, long history of multiple niggling injuries, which have kind of really limited her play time over the last 48 months. She has niggling shoulder pain, which flared about 6 weeks ago substantially. And she's failed a return to play. We think it's probably an impingement of some sort. And there was talk of an injection, but she has actually settled now.
Okay, so anyone except for Steve or John got questions, and then we'll go to John, just because he's under a bit of time pressure. Any hands up? Nick. You're top of the screen, mate.
Annabel, are you testing your rotations in supine?
So they're actually being done at the LTA. So the rotation work, because they started doing them, so they wanted to keep doing them for continuity. So the rotation at 0 is in sitting, and then the rotation in this position at 90 degrees. Initially they were doing it in sitting, but they've now swapped to doing it in supine. For whatever reason.
Yeah, my understanding is that supine's much better based on Karen Ginn's work with the unidirectional rotator cuff, and all that. Like you, I'm not aware of any particular ratios that are evidence-based, but with my work in tennis, we've always aimed towards 1-to-1 in that supine 90-90 position. And obviously got weak versus pain inhibited versus MT, all those kind of things. My main thought is, what's her general posterior chain like? Because most tennis players I've met at any level, especially if the problem's on the forehand side, then their posterior chain in terms of eccentric loss of control, in the follow through, is always poor. And just sorry, do you know whether her pain is on wind up contact or follow through? Yeah,
so she wasn't sure herself initially because it just hurt all the time, but it's now generally just at the end. It's gone to now just being at the end of her follow through. Yeah. Initially it was on contact as well, but we seem to have kind of sorted that out now, and it's just that end of follow through. Yeah,
no, that's great. Things I've looked at, I do a lot of that supine 90-90 testing with my tennis players and seem to get quite a lot of benefit out from it. But I would be tempting you to look at her total posterior chain and very much looking at that final eccentric control there, because those posterior cuff muscles are working incredibly hard to decelerate her racket at that point, getting ready for the next shot. Yeah, that would be my primary thoughts. Just I'm still mulling it over in my head, but sorry, if I can add one more thing. As you mentioned the 12-year-old thing, and so I've seen an awful lot of adolescent tennis in my life, and I suspect that a lot of them are proximal humeral epiphyseal problems. But that should settle down, of course, eventually with age. But none that I've ever sent to sports med ever come back with positive MRIs, interestingly, through that area. However, they do present in both directions when you test them passively and actively. So I can only start to think that it's more of a passive structure that's the problem rather than an active structure. But that is not her problem now.
Yeah, sure.
Thanks, Nick. Susan, I've seen you with your hand up, but we're at risk of losing John. So if you don't mind, I'm going to let him go first. John Baxter, any thoughts, any role for yourself?
Yeah, sure. Thanks, guys. A couple of things. Great case, first of all, and excellent presentation. Let me know if I cut out, by the way. I'm just walking down a stairwell into work. I couldn't agree more with everything that's been said so far. So it doesn't necessarily sound like it's something traumatic structural within the shoulder. It certainly sounds like there's a lot going on in terms of the scapular coordination, and that obviously seems to be now even at rest with your examination findings. It'd be interesting, when she went back to play, when you described the niggling symptoms, was that at the front or was that at the back?
Yeah, so initially, like in the past, it's always been anteriorly. This most recent episode, it was anteriorly, and then it spread to a very diffuse kind of pain everywhere. And that's now resolved back to actually more of a posterior pain now on that follow through. But it is, she's now not getting any pain at rest. The only time she feels it is when she overexerts on forehand.
Yeah, sure. Because there's a few different things that can be causing it. Obviously, like you said, with impingement, but there's different types of impingement. So pain at the front, over the pec insertion, over the coracoid. You can develop subcoracoid impingement essentially at the front, where the subscap's becoming unhappy because of your internal rotation, probably on the follow through from things like serves where you're coming across the body as well. That can cause some discomfort. And also, if you think about the amount of stretching at the back, both of the posterior glenohumeral joint structures, but also of the periscapular musculature when you're coming through on those serves. If there's any kind of, not necessarily laxity, but you know, if she's tall, healthy young lady, she probably does have a slightly more lax shoulder than some others perhaps. Then all those structures are getting stretched as well when she's coming through. So I think really focusing on that rehab for the scapular setting and in cuff rehab will help her. Yeah. The reason I was differentiating the two different types of impingement, internal impingement posteriorly, that's what the American baseball players get, where they are hyper-external rotating in abduction and pinching the back of their cuff. She might be getting that on on the serves, so that might be what's causing some of the pain when she goes back to serving. But those two entities probably wouldn't be affected by a subacromial injection.
Yeah.
Because a subacromial injection would help the classic type of subacromial impingement, which she may have, but she's certainly not presenting as a classic patient or history or examination findings for that.
And she definitely had quite a painful arc initially, but that's completely resolved at this juncture. So I think she's just, as an athlete, keen to do everything she can. And I'm sort of saying, I don't think an injection now is going to be helpful for you because you're not really getting any of those signs that suggest that you've got a raging SA bursitis. But yeah, I was just really interested to see what everyone else's thoughts were, whether there was anything else that could help speed her along.
Yeah, the other thing is it's unlikely that an ultrasound scan would have showed you much in there if you're looking for internal impingement. If you're looking for that sort of thing, you're probably talking about an MR arthrogram to look for that posterior superior labrum, but also...
John?
Yeah, sorry.
Okay. We just lost you there a moment, John. I think you were saying perhaps do an MR arthrogram if you were wanting to look for a posterior superior impingement, I think you said.
Well, yeah, posterior superior labral pathology or bursal-sided cuff tear. But in someone who's that high functioning, neither of those would really be. I wouldn't be that keen to offer any operative intervention for that. Mm-hmm. So I think an MR, any further investigation at this stage, I don't think is warranted because she's doing well. But the next step, I probably, if she was having a lot of ongoing pain and wanted further investigation, an MR arthrogram would probably give you more information.
Okay, great. Thank you.
Thank you.
That's okay. My apologies. If you have another case, I do have to nip off, I'm afraid.
We'll cope.
Very kind of you.
I've got Steve to back me up.
Nice to talk to you again.
What a labour. Susie, you had your hand. Thank you, John.
Yeah, I was just really following on from what John said a bit there with the scapular control, because you said she gained better, I think you said flexion or abduction with more scapular assistance. So possibly looking at getting that movement, but functionally when she's playing, maybe possibly with some taping to help her to facilitate a bit. But if she's not getting that end of range scapular movement, she's going to struggle with the end of range elevation and that she needs in her serving and stuff. So
yeah, it's something that we've thought about. She gets a really horrid tape reaction in the past, so it's actually something that we sort of thought we'd leave as a backup option that maybe could teach her coach just to tape her directly before a training session and then take it straight off. But just because around that tape allergy issue, I'm always reluctant to try it if we don't have to. But yeah, thank you for reminding me, because it is something that I did have in the back of my mind initially. Her scap control is much better now as well, so fingers crossed she won't need it. But maybe for when she returns to match play, like if she's fatigued towards the end of a tournament, it might be a really good other option to pop on just before she plays. So yeah, thank you, Susie. I think you might be muted, Jonathan.
Mark.
Thanks, John. Thanks, Annabel. That was really good. I'll just go back to something that Nick said and try and put that together. The enthesiopathies are something with these youngsters, and my experience way back there with these little ones is, and she's got a history of being really quite keen, right? She's got all the trackings of a female triad there. When they have the enthesiopathy in the rotator cuff for the youngsters, they start to run around the stroke, and so they get these kind of hitching components to stabilize so that they're not using the rotator cuff. And from my experience, that's where the rib 1, rib 2 kind of elevations start to play into account. Mm-hmm. So the first point there is if it would be possible for you to get down and see her in what other people are calling a great return to forehand play, that would be very, very beneficial to see whether she is regressing into, Western grip, throwing the shoulder forward, hanging off the soft tissue of the shoulder without actually using strength to power her forehand through until she actually gets maybe an enthesiopathy and maybe even a little bit of bone growth. I mean, that would be disappointing, but that goes to the next point. I wonder whether we've got some of that, a bit like a Osgood Slatters that grows a bit, and there's something within the tendon, and I am not clever enough to know whether that would show up radiologically or not. So that's where the scapular setting comes in. And I was fascinated about the tape. I have been known to tape over the top of a crop top and tie it down, and or use the strapping on the back of the crop top to achieve what you're going to do with a piece of K-tape, so that they've got to force down and got to force back. And the point that they like is that it's not painful when they get it going right. So they go, oh, we can do this. Yeah, right? We can do this. And I like that. And that makes me hit the ball in front of the line as opposed to in there behind the line of offset. Right. So you're assisting her changing her stroke mechanics, which should, in retrospect, reduce the load that you're putting onto the shoulder and the stresses therefore. But that's the ability to get down there and have a look-see.
Yeah, great.
Great case, really interesting.
Nick next, and then Katie's just flagged up something that was in the history which we should probably address around her hormone cycle. Nick.
Annabel, just another little thought potentially about rehab. I'd probably use this more if the pain is on contact than on follow through, but shoulders and tennis shoulders like that, they often develop a bit of an increased draw just because of the hyperlaxity in the anterior capsule and so on. So what we might end up with is just a subtly wobbly shoulder that's not well controlled and well centered by the active constraints. So weight bearing work is always really high on my priority. And if the problem is overhead, then I would potentially get them inverted and into, you know, handstand or resisted handstand positions, and then try and do some work in there. And if it's over here, then again we've got to try and potentially get them into that. So just a thought in terms of rehab, if you've not been going down that road, and maybe see what her anterior posterior draw feels like passively to get an idea of her shoulder there. That's my thought.
Yeah, she's definitely looser on that right shoulder than the left. You're exactly right. I've just started this week doing some work from planks round into side support and then back under into some thread the needle stuff. So we'll see how she's tolerated that. But we just started that this week because the first time I saw her, she couldn't single arm support in 4-point kneel. She didn't have enough control. So I'm hoping that because her control was so rubbish, that actually just getting her better from a control perspective is going to sort it all out for her. But fingers crossed.
Because if I remember rightly, the cuff doesn't work massively well in closed chain, but of course the scap stabilizers are going to work incredibly well in closed chain. So you can use the open chain to work the cuff and then the closed chain to work the scap stabilizers, and hopefully that blends together into a good shoulder.
Yeah, great. And yeah, she'd done a lot of open chain stuff already, so and it hadn't kind of got her to where she wanted. So that's why we sort of started the closed chain stuff and just restarted some open chain stuff again as well. So fingers crossed.
Really interesting case.
Thanks, Nick. Susie, have you still got your hand up, or did you have a... Okay. Anyone else got anything? Otherwise, we'll come to Katie's suggestion. Annabel, Katie just flagged up that in the history you mentioned hormone, menstrual problems, and address that. And perhaps we can ask Steve if he's got some thoughts on that in who's amenorrheic.
I think the alarm bells are already kind of ringing as you're going through that history. This sounds like a player who has previously had an eating disorder, if not has an eating disorder now, has had red S, is going to be on the spectrum where she will overtrain. And I wonder whether she's been truthful with you in terms of her training. And then again, what Mark was saying and what Nick was saying there, is she basically really training in that kind of open chain, because that's the kind of activity she likes to do, i.e. active serving, etc., but not doing the stability work around that. In terms of what Mark is saying, is she actually not telling you how much she's actually doing, and is this kind of enthesopathy because actually she's doing extras around this? Those are my kind of immediate thoughts. So one of the things I was wondered was whether Jonathan would have wanted to get an MRI to see if there was anything that can show up. I wonder whether that kind of instability and enthesopathy in the right hands of a radiologist, maybe can there be any inference of that? I don't know what you'd think about that, Jonathan. I don't know if we've got any radiologists on the call, but yeah, those are my thoughts.
Yeah, so she's got a manager now who is a physio, like a return to performance manager, because she's had so many issues. I know she's seeing, I think it's an endocrinologist and a nutritionist as well. So they definitely, and she's 26 now. She was amenorrheic 15 to 21, so she now is cycling, but she still has low progesterone. It sounds like to me, speaking to the manager as well as the player herself, that she is fairly heavily supervised most of the time. But yeah, we don't know what she does on her own time. But she's now kind of, initially she was very much wanted to play qualies, like Wimbledon qualies, and she kind of has now decided that no, she's now planning this whole grass season is for her to rehabilitate herself. So I hope that maybe her mindset is starting to kind of come around to that concept of, look, she's got to put the work in now and you know, follow the kind of the suggestions of everyone. But yeah, I think they're all very good points.
I think it's the quality, not the quantity with her, but her brain will be saying it's the quantity, not the quality for her.
Yes,
and,
so
that's the
yeah, I've had to say, like, she was like, so I can do these exercises every hour, and I said no, that 3 times a day, maximum 3 times a day. So she's been doing them 3 times a day because you know, but she's been the opposite of most of my other patients that walk in the door where you tell them to do something 10 times a day in the hope they'll do it once, and you're like, no more than 3.
You almost have to be prescriptive in minutes through the day. Yes, actually resting is actually giving you some advantage, and is part of your rehabilitation.
Yeah, unfortunately, she's still rehabilitating this pelvic stress injury, which is going quite well, but at least that sort of is another block of time that she has to spend loading that. So she's got some time off her shoulder as well.
Sounds like a very, very interesting case, Annabel. I'm tempted to put you on the spot and say, what are the take-home messages you've learned from that? But it might be a bit unkind. But I did think if I did that to you, then it would refresh your memory, and also people can interject if there's stuff that you haven't managed to scribble down or remember, because I think you've had a whole heap of stuff there to take on board. Just briefly, what's your main take-home message from the meeting? I think the first is that you're right not to want to inject her. Nobody wants to inject her. So you can tell the player that 19 people don't want to inject her.
So I think as well, I'll have a bit more of a look at her posterior chain overall. I hadn't really assessed that much yet, assuming that it was getting done with her pelvic rehabilitation stuff. So I'll definitely check that, and having a look at kind of deceleration load up into the follow through. And probably also, as Steve was saying, just double check that everything is from a load perspective, that she's not overcooking things. And probably also as well having another look at her scapular control and whether in fact it is worthwhile revisiting the taping option. Definitely having a look at her doing some play time, whether that be I can get down to the court or we can at least get a video through of her session that I can watch from afar. They're probably the main things that I got out of it. If I've forgotten anything, if someone else, please let me know, because I wasn't typing it as I went.
I think from my point of view, given that most of this is complete gibberish to me, being a knee surgeon, I think you summarised everything I picked up there. I think the video is quite a good idea, and I found some of the youngsters with tennis players, I mean, they've got the usual pressures to perform, etc., whether it be from a parent or otherwise. And I think the video footage is a good idea. I think that was Nick's suggestion, and you can glean quite a lot from. Sorry, it was Mark's, wasn't it? You can glean quite a lot from even just some simple iPhone footage. Saves you having to go down to the club.
Yeah, well, I might just get her to, or even because I can even do it at the same time as I can watch it live as well with Zoom and things like that. Just get her to set up her phone and I can just sit there at home and watch as well.
So thank you very much, everyone. I think that was a great case.